So we want to basically go through a summary of information for the CY20 OPPS Proposed Rule, and then also provide some comments that we've prepared as we actually are planning to submit our kind of final remarks into CMS, and want to basically to provide some of these out to other kind of stakeholders as you begin to prepare your documents as well. The deadline for submission is September 27th at 5 p.m. Eastern. So obviously that date is upon us. And again, there's a lot really that's contained here in the rule that we're hoping that CMS can hear from a number of people, as some of the things that are being requested are really quite dramatic. And in many ways, we actually think a number of them are not actually logistically possible for a hospital to provide. And so as we go through, we'll try and, again, pinpoint not only a summarization of these key areas, but then also some suggested comment back for your consideration. In thinking through kind of the proposed rule, some context or history is really kind of important. And this goes back to kind of ACA, where there was an original call for pricing transparency that was included in that legislation. We then kind of got a reminder in the FY15 IPPS proposed rule that hospitals need to either make their pricing available to the public by posting the CDM or by some other means necessary for access. And really the way that most hospitals at the time complied with that portion was they felt as if kind of there was a means for a patient to call up or to send an email or to reach out to the hospital for a price quote, that was sufficient. And in fact, it was based on the language that existed at the time. Take us back then to last year with the FY19 IPPS proposed and final rule that really kind of began to get more prescribed on what needed to be provided as far as the disclosure was concerned. So within that kind of IPPS final rule, excuse me, there was also some responses to frequently asked questions. Some of what we're seeing right now in the CY20 proposed rule is actually reflecting back on those responses to frequently asked questions that a number of folks actually missed. And so what we're seeing is kind of those responses being officially introduced into official rulemaking. Of course, then in June, President Trump signed an executive order calling for additional transparency policies, and the rulemaking body essentially used the CY20 proposed rule as a means for complying with that executive order. So kind of that's the context of how we got, from here to there. The specific language that exists today is really also very important, and I'm going to just kind of focus in on this key one on the green area here. And this is the requirement states that hospitals need to make available a list of their current standard charges via the internet in a machine-readable format, and to update this information at least annually or more often as appropriate. This could be in the form of the charge master itself or another form of the hospital's choice. So a lot of what we see in the CY20 proposed rule is to essentially take these very simple statements and to provide more requirements around them. So, for instance, what we saw in there in terms of questions that we were asking back as a result of that, as a result of the final rule last year, were, what is the required format? And again, it really came back to the hospital's got the discretion to provide the format that is best for them. What items and services are supposed to be included? Well, the rulemaking came back and said, or this responses to frequently asked questions came back and said, you've got to include drugs and supplies, even if those items aren't reflected in the charge master. So that was a big no. PDFs did not satisfy as machine readable. That basically every hospital really needed to provide this disclosure. Number 5, the kind of participation in online state transparency sites did not satisfy the requirements. and that the hospitals must also post charges by diagnosis-related groups, and that enforcement actions could come in future rulemaking. So basically, all of these items really have been addressed in the CY20 OPPS proposed rule. What we saw as notably absent last year was a definition of standard charges. So there was some discussion of, gosh, what do we do? And to a certain extent, this confusion still exists today, primarily in the form that if you maintain multiple fee schedules, there still is not a provision in place for what to do in those situations. So, do we use a default price? Do we use an average price by code? Is it our most commonly charged price, our highest price, our lowest price, a listing of all prices, again, if we have multiple fee schedules that exist within the charge master? All of these things are still unanswered and would be at the hospital's discretion. Again, this could be a basis for your comment if you would like. Our personal approach on this is, maybe let's not prescribe anything more on there in these multiple fee schedule environments, which can, again, be very challenging to provide. So CMS may be recognizing this and, again, giving the hospital some latitude there on that specific definition at least. But again, we're going to get more into how they have refined the definition of standard charges in general. Drugs and supplies, of course, are now a part of the disclosure. There has been some discussion as to how to approach those, whether to use what actually exists in a CDM, whether that be a null or a zero price. That certainly is still on the table. There's nothing in the rule that would suggest that needs to be different. The other is sort of to use an average price or an average charge for that, especially in a situation where there could be a shell code or so forth used for that. Again, those all still would appear to be in play and acceptable given the current disclosure requirements that are being proposed. There are some other areas on here that really aren't addressed, and we're not going to spend these in much detail. Inactive codes, codes with no usage, again, we've got some provisions there for consideration. But the big key here on this particular slide is notably absent last year was basically anything that had to do with professional charges or other entity charges. Essentially, this was omitted, and the language read that it was each hospital's responsibility to comply. And so at the time, again, most folks kind of interpreted that as being only technical charges. That, again, has also been addressed, and now professional fees are also included in the disclosure. And again, we'll talk more about that in just a moment. So what are kind of the 9 areas that are included as far as transparency is concerned in the CY20 OPPS proposed rule? We're going to kind of get into a lot of these keys, but this slide kind of refers to these, again, for handy reference. And again, we'll make these slides available after the presentation as well. But let's start to dig into kind of some of these areas. The first is kind of a definition of a hospital and the different kind of reporting requirements for different types of hospitals. These are 2 different kind of areas within those kind of 9 that are provided in the CY20 OPPS proposed rule. So essentially the summary here is CMS is really kind of providing in the rulemaking now that the only exemptions to hospitals that would have to comply are federally owned or operated institutions. And the rationale there is that these facilities, they are not accessible to the general public except in emergency situations, and they do make their charges publicly available already. So they are kind of deemed to satisfying the requirements that are there. The other kind of notably absent ones there are ambulatory surgery centers and then non-hospital sites of care, so kind of lab and imaging centers. Those are also excluded from the disclosure requirements. Our kind of comment back here really is that it probably was only a matter of time for them to kind of officially document who was or who was not meant to comply. This information really was in the responses to frequently asked questions, and so again, we felt like it was only natural for them to put that in there. There could be a case that could be made for folks that are not prospectively paid. So we think about our critical access hospitals, to kind of comment back potentially and say, this DRG disclosure that you're requiring me to make, I'm not paid on that, and so I don't feel as if I should have to provide that level of detail given that. And again, if that's your stance, certainly that could be an area that you might want to make comment on. But again, the thought here is it really was probably only a matter of time for them to kind of clear this up in the official language. We then get into one of the very largest areas of concern, and this is their definition of standard charges and also their definition of items and services. And we've combined these two because really the combination of the two is what makes the disclosure problematic for hospitals to comply with. So CMS is proposing defining standard charges as both gross charges as well as what they call payer-specific negotiated charges, and essentially that latter refers to the payment rates that are agreed to by the hospital and the payer. In addition, CMS is defining what's meant by the pricing information for all items and services to be inclusive of three categories. One is all items, and you can think of this as being all individual items within the charge master, inclusive of drugs and supplies. Again, going back to the original intent, even if drugs and supplies are not inherently in the charge master, if they're stored in a separate kind of reporting kind of mechanism, again, they still want those items included in the disclosure. They also want to see service packages, and they're defining that to mean any aggregation of an individual items and services into a single service with a single charge. And that's a really key point to focus on, this definition of a single service with a single charge. So what they've kind of recognized is there are a number of other kind of payment forms that the hospital has that really don't fit kind of into these individual items and services components. So they think of kind of DRGs or per diems or other kind of service packages that may exist for the outpatient setting, like surgery case rates and so forth. So regardless of how you've defined them, they want you to provide all of the pricing and payer-specific negotiated charges for those different service package aggregations. And again, we're going to revisit this in just a second. The final is they also want to interpret this to mean all professional fees, but here's the caveat, only for employed physicians and non-physician practitioners. And our summary comment for all of this is that the combination of these definitions really pose significant challenges for reporting, and in many cases are not technically possible. So we understand the intent for each request, and so what we're going to try to do is kind of provide some type of a matrix here to help CMS understand where these definitions are problematic. There's a lot of information here, but what we've chosen to do to try to kind of illustrate what CMS is after is to kind of create a matrix here. And on the vertical side, we've got the definition of standard charges, and on the horizontal side, we've got their definition of items and services. So on the standard charges, obviously, again, we've got gross charge and payer-specific negotiated charge. On the hospital, or kind of the items and services side, we've got the hospital technical kind of component, and then we also have the professional component. So let's walk through this as a group and kind of, again, break down where this is going to be possible and where this is going to be, not technically possible to provide. So obviously, the gross charge at kind of the service kind of per unit level, these rates are stored in the charge master, and they are already a part of the FY19 IPPS disclosure requirement. So obviously, this is not an issue for hospitals to provide, and they are, in fact, a part of the current disclosures. However, when we think about trying to provide essentially a CDM and then columns going across for every single payer that you have contracted and what the rates would be there for their payment, this gets to be not technically feasible because for many hospital contracts, their payment rates are not built at kind of that that per line item level. The rates are more kind of, again, at this more packaged level. And so unless the contract were entirely percentage charge, this type of reporting is actually just not even technically feasible for a hospital to provide. And so we really want CMS to be able to see that kind of in the conclusion. In more of our in-depth kind of reporting back to CMS, we actually have done some research to kind of determine that less than 40% of payers nationally across all hospital settings actually have an all services percentage charge payment relationship. And so, again, that means 60% across the entire country would not even be able to kind of be fit into this reporting requirement. So, not possible from that perspective. We then get into this service package, and we actually are trying to illustrate back to CMS a difference here that we think there may be some confusion on. When they're talking about service packages, they've kind of defined this as essentially these custom definitions, sort of, it could be a per diem, it could be an outpatient case rate, it could be any kind of carve-out area within a contract. And when we think about those situations, really these are what we'll call custom defined and multiple payments per claim, where a hospital would have a challenge actually providing back a gross charge and potentially even a payer-specific charge back. And let's talk about that for just a second. So from a gross charge perspective, these technically fall outside of kind of their definition right now of a single service with a single charge, because hospitals really don't set a single gross charge rate for these type of packages. You think about an inpatient per diem. You're not calculating that out for or establishing a gross charge and storing that in the charge master. Now, you could think about, well, I guess we could get to some level of an average charge for these types of service packages, but these really would get to be highly burdensome to provide because the charges are really dynamically assembled for each unique claim. And this begins to be a real important lead-in that we want to make for CMS, that where we think that they are after, or what would be more relevant to provide, is kind of a charge at the claim level, not a charge at the kind of service package level, because again, you've got custom definitions, you've got hierarchies with regard to payment and so forth in these situations. We also kind of want to kind of recognize here that these categories are not standardized or utilized across all hospitals. So if the patient is trying to kind of use this as a benchmarking tool, which again is a real key component that CMS is promoting here, well, there's really no ability for the patient to benchmark, because a per diem may exist for one hospital and it could be a case rate or a DRG rate at another hospital. So how is the patient supposed to kind of benchmark those areas across different hospitals? Again, problematic from that perspective. On the payer-specific negotiated charge, again, these categories are not consistent, which would make comparison difficult. And also, it would take the patient sort of trying to sum up different iterations where, again, there could be multiple payments per claim. That would be very difficult. The other key thing here, and we're really hopeful that some of our kind of professional institutions and representative kind of organizations like AHA and also HFMA will really kind of provide some legal kind of opinion into this, because CMS states this in the proposed rule, and we also kind of wholeheartedly agree that including payer-specific negotiated charges in the disclosure document really sets this up for significant legal and anti-competitive action. And so we're trying to emphasize that point in there, but again, we hope that others will, and specifically others that may have again a legal kind of background that can comment specifically on that, I think would be very helpful. So again, just a side note, if you've got an internal kind of legal counsel team that might want to speak specifically to that point, I think that could be a very desirable thing to do. The other thing that we come back to that we summarize here is that fundamentally we believe payer-specific negotiated charges should be provided by the payer, not by the hospital. And that's a big key point that we keep trying to hit home. The payer is going to have the ability to provide more up-to-date and real-time information for the patient. They also, because they will know the rates that they negotiate with each provider, the tools that they could provide the patient would be much more robust from a transparency perspective, or to help a hospital, or a patient to shop across hospitals, because again, they would have access to all of those rates and more real-time information for the patient's own, kind of year-to-date, medical expense. So, again, these are really kind of key points to consider there. What we now transition to, though, is a green area of what could be provided, and a big piece that we want to kind of provide back here is last year our firm really in our kind of responses to CMS talked about all of the reasons why the disclosure requirements that they were providing or calling for were problematic and potentially would not be utilized by patients. We did not offer up alternative solutions or areas that could be provided. And in hindsight now, we see that as a miss, because what happened, I think, is we were probably not unlike a lot of other people that basically came out and said, don't do this. It's not really going to be kind of worth the effort. And CMS just said, hey, you know what? We didn't get responses on what could be done, and so we're just going to have you do it. And what we hope to do this time is to try to show, well, what could actually be done? And what we think CMS is potentially trying to get after, that again might be more relevant for the patient too, is where do we have a standardized definition and a single payment per claim? Again, this is different than a service package. What we think needs to be defined as is a per claim, kind of charge or payment disclosure, because that's really what the patient is after in all of this, not a service package, definition. It really is a claim level definition that would be most helpful. So what is a system that exists today that actually has a standardized definition and could be applied across all hospitals? What would be the MSDRG system? This particular disclosure on the gross charge side is already a part of the FY19 IPPS disclosure. So, this piece already is there. What could be done as an extension of that disclosure then is if payment is really sought after here or desired, an average payment across all payers could be calculated for the hospital so that a patient could get some understanding of the underlying payment to gross charge relationship. And we feel like this is somewhat of a middle ground to present back to CMS for consideration. It avoids the payer-specific kind of disclosures, which again could lead to significant legal action, but it also provides some level of payment to gross relationship and would be an extension of an already kind of included requirement that's provided to hospitals right now in their disclosures. So again, this is our approach back to kind of say we feel like this is something that could be a nice middle ground to present back. The final one over here is professional, and our statement here, back to CMS is, while these elements could be technically possible from a gross charge, and to be honest, even from a payer-specific negotiated charge, because on the professional side, most organizations follow a CDM disclosure that's basically at the HCPCS CPT code level. And a lot of their payment rates are essentially at that level as well. So, that hurdle really probably would not exist to the same extent that it does on the hospital side. However, the real problematic piece here for providing the professional fees is that the requirement is for employed physicians, which makes complete sense. A hospital would not be legally allowed to disclose, pricing or payment information for, physicians that it does not own. However, because that employment can vary so significantly across hospitals, where one hospital may do that, another hospital may not, and so you have those situations where comparison now would be very problematic for a patient, but also even within a hospital, you could see significant variation where a certain service line does kind of have employee docs and another service line does not. That could present an issue for comparison. And finally, one of the biggest keys is many of these kind of ownership models technically fall outside of the hospital's purview. It could be a foundation that actually has that, or another kind of entity within the health system that does. So how do we kind of address these very complicated areas? And again, given all of the other complexities around comparison, really we're trying to promote back to CMS that this is an area that should be omitted from the final disclosure rules. So lots of information there, but again, hopefully visually, we're hopeful that presenting this visual back to CMS will help kind of solidify what is and what is not possible. Because I think, if you've read through the hundreds of pages there, there's a lot that's there, and I think in some ways they might not be connecting all of the dots in terms of where these requirements are connecting and where it can be a challenge to go forward. Here's kind of that just visual of what we saw. We actually took 5 major plans that exist for most hospitals around the country and showed even by payer where there is significant variation. So here's major payer 2, where only 11% of plans nationally have all services paid percentage charge, and almost 90% do not. And again, you can see that variation across payer, and this certainly becomes problematic on those payer-specific, disclosure requirements. Then we get into kind of some of the specific requirements on, all right, what's that disclosure document supposed to look like? Again, last year they kind of said, it's, at the hospital's own choosing. Now they're saying, no, we're going to prescribe some things here in how you've got to do it. Well, one is you've got to include a description of the item or service. And again, this is in that just giant CDM disclosure that's machine readable. They want a description that's on there. They obviously also want the gross charge that we've talked about. They also want that payer-specific negotiated charge, which again, we've talked about why that's problematic. They would like to see a billing code. So if you use a HCPCS CPT, an NDC, which again further solidifies this comment back that they do want to see drugs, or a DRG. So again, where applicable, if they're now including kind of this service package kind of element, that would be in there. That has got to be on there as well. And then a revenue code as applicable. They also now are kind of providing back some examples of machine readable. Lots of discussion last year in terms of what was, would satisfy the requirements. They're now pointing to things like an XML, JSON, or CSV kind of structure that could be provided back. Location, they want to really see that the hospital is not providing any kind of restrictions. Really, the intent is for this big document, they really want this document to be served for developers, where web crawlers can go out, kind of bring down this information, and the thought is that this will unleash within kind of the free market developers to go out and provide back all of these tools for patients to be able to shop and compare. Well, with that, the location has got to be prominent then. And it also has to be without barrier to entry. So last year there were some examples where hospitals might have had a, kind of a submit kind of an email address or so forth. They're basically saying, no, there has to be with, no barriers there to kind of entry. And then updates again, at least annually, and that the last update must be clearly labeled. our thoughts really in here is much of this is probably to be expected, honestly. I think it was probably only a matter of time where they required a HCPCS CPT code. Why? Because that's what enables comparison. So again, most folks last year just used either a description or an item code and then had the gross charge. And obviously that's not super useful for comparison, and they've now seen that. And again, they've made a provision there. More than likely, I think this information is going to get through. So I think we should be prepared for having this, included in the final rule. I don't see much probably room for kind of negotiation back. I think it's really just extensions of what was there before. But again, certainly that's only our view. Here we get into another big area that was a part of the proposal. And this is a separate document that is for a consumer-friendly display of, and big note here, payer-specific charges for select shoppable services. Now, in my first read of the proposed rule, I made an assumption that was this document that they were looking for was to be provided for both gross charge and then also payer-specific negotiated charge. But if you read it closely, and again, as I started to read through and started to really, again, try to pinpoint, okay, how are we going to respond back? What are the specific requirements here? What you will find is you do not see any mention of gross charge. It is only, and even the heading is such, payer-specific charges. So whether they realized it or not, it does have just the payer-specific charge here, not the gross charge for this particular disclosure document. So what we kind of have commented back is, one other kind of point in here, the quantity of what they want to see. They've prescribed 70 codes that they say, these are the 70 that everybody's got to provide, back to patients on. But we also want to see at least 300. So you've got to provide, 230 at least of other items that you think you'd like to have in this more consumer-friendly display. And so, our comment, while we agree that a separate disclosure of really highly shoppable services would be beneficial for consumers, there are some challenges that are inherent to doing this as it's written right now. And one other kind of quick comment, they've defined shoppable to be anything that can be scheduled by a patient in advance. So that's their definition of shoppable. But the reason why kind of this gets to be very problematic is, again, thinking that right now the way that it's written is that it's a payer-specific charge. We come back to that fundamental point that we made earlier. Payment is typically not at the line level. And so, payer-specific negotiated charges really don't exist for most, if not all, of the items that are currently on their list of 70. So that begins to be a key hurdle. The second is hard-coded prices and payments may not be established for some of these items. So, specifically, if we think about kind of their surgical kind of code list, well, hospitals typically don't maintain a gross charge and may not maintain a payer-specific kind of negotiated charge for those because it's being driven on the level of time that's invested kind of in that procedure. And then again, HIM is making some kind of soft code assignment on there. So again, that's a big key in all of this that, again, does not make this to be, as it's currently written, the ability to be provided. And then the third is they would also like to see any ancillary kind of charge that is a part of that item. So you've got some type of a colonoscopy. They want you to say, well, here's all the stuff that typically is done. And there is no format that's prescribed for that right now in the rule. And really kind of what we're pointing back to is this could be very difficult to display for all payers for all codes. When we think about that level of documentation back, we really kind of get outside of it being then user-friendly. So how do we try to provide comment back to them? Because again, we can't just say, this is all garbage, you can't do it, so just take it all out. So here's kind of what we're trying to kind of get back to them. And this is a display right now of this, ancillary charges around one of the codes that's on their schedule. So they've got HCPCS 45385, which is a lesion removal colonoscopy. The Case Hospital here has a charge of $2,681 for this. You can see that here are the other areas that are included that would be done in conjunction with this. So you've got 8% of the time GI endoscopy biopsy is done with a charge of $1,246. And so forth. And so as you go down, you can see some of these additional kind of items. And the question back then is, well, where do you cut this disclosure off? And having then to do this for every single payer, again, as it currently is written, my goodness, the amount of data, we've now gone way outside of the bounds of trying to make this consumer-friendly document. So how do we try and kind of shape this? Well, first off, our kind of approach back to CMS is to say, let's kind of whittle this list down. Let's keep the 70 that you've got, but let's kind of modify, instead of 230 hospital-selected services, let's just make it 30 additional so that we've got an even 100. And again, if you want to try and expand that out over time as you start to see patients using this, let's be mindful of that. But to start off, let's just keep this a bit more manageable and make it 100. They've called for a plain language description for each shoppable service. We're saying, yeah, go ahead, maintain that. I think that makes sense. This next area is providing for the payer-specific negotiated charge that applies to each shoppable service. What we're saying is, let's modify that to the average gross charge, and let's remove the payer-specific kind of charge for this, again, as these really don't exist for most hospitals. At that. They've also said, let's, again, look at all of the associated ancillary items that are included with that service. Well, what we're saying is, let's modify that to be, again, the average claim charge for the primary item and all associated items. So what that might look like is this. Here is the lesion removal colonoscopy. It carries with it a charge of again, $2,681, and on average, when we look by claim across all payers and across all associated codes, we see that the average charge for that would be $4,124. Again, this is a much, much easier display to put together for the hospital, and it's also a much easier thing for the patient to consume, and again, really gets at the heart of what I think they're after. What are kind of the elements that could be surprise billing, if you will? That's the stuff that they keep coming back to. Well, in general, this gives them the ability to see that. Yeah, your procedure's about $2,700. Yeah, you could have some additional things that could take you to around $4,000 when it's all said and done. The next is they've got some, language in there that says, hey, you've got to also kind of include if there are different campuses or clinics and so forth. Well, gosh, if we think about trying to provide this out, again, you may not store this information at that level in the CDM. So to kind of come up with this across all of your clinics, across all of your different, maybe even departments and so forth, this could be really problematic. So our modification of this is to make this component optional for gross charge reporting, again, removing that payer-specific negotiated charge. Again, the hospital may not have separate pricing even at these areas, and if it does and it wanted to promote it, well, it would be incented to promote it. So let's just keep this area, optional. And then the final is maintaining kind of that primary code that's used. Again, this is really would be on there through the other disclosure, the CPT code or HCPCS code or DRG. Again, that's not problematic. The last area that we come to today is really this non-compliance area, and there is now kind of some teeth behind the requirements that now are penalties calling up for up to $300 per day. And we've done the math. That would essentially equate to about $110,000 per year for a hospital that was not compliant. So again, if you've got multiple, hospitals, obviously that would that could add up. And again, a commenting period kind of ending on the 27th. But final thoughts in all of this, and this I think is really key. We actually are kind of hopeful that maybe some comments will come back to CMS along these lines. We're planning to provide it. We want to emphasize to CMS that we do support reasonable efforts to continue to help patients understand the financial implications of their care. I think as we've talked to hospitals over the past months about these requirements and so forth, there's nobody that says, I don't want patients to kind of have any access at all. I think that the thought is we're just concerned that patients sort of seeing some of this, there's a lot of challenge in terms of communicating this in a way that a patient actually understands. And so let's kind of create more of an evolution to this as opposed to a revolution in some of what's being asked here. The other big thing is a lot of the information that they're requiring, again, is not technically possible and could lead, in fact, to a number of unintended consequences, including legal action and, again, anti-competitive behavior. One of the biggest things, though, and this is where we will close, is we are concerned that much of this additional disclosure information will go unutilized by patients. And in fact, CMS in kind of their introductory narrative really goes on a defense of why the promotion of this kind of additional transparency information is going to lead to reduced costs, increased patient benefit, and so forth. And in reading kind of the proposed rule, one of the citations that I saw that just struck me a little bit was kind of a JAMA article that at least the way that they were using it was kind of for the number of state kind of reporting sites. And I kind of wanted to just visit that. And as I read that article, the main premise of the article had nothing really to do with the number of transparency sites. That was a very, very essentially kind of random kind of element that was just quoted in that article. But the premise and the underlying kind of outcome of that article was to say that there's a few things. One, transparency tools are actually not associated with lower outpatient spending. So this is a huge sort of flying in the face of kind of the things that are being promoted here. One of the reference citations that they're providing actually runs counter to what they are suggesting this will do. And that, I think, is a really key point to emphasize. The other kind of things in this particular article cite that transparency tools have low patient utilization. So what they found in their study, where they worked with two very major payers, employers on evaluating the use of these transparency tools, was that less than 10% actually logged on in the first year of their introduction. And so this, again, gets to be problematic and probably falls in line with some of what your own experience has been. Was talking with a hospital earlier in the week, and one of the things that they were going to do, which I thought was really excellent, was to actually pull some usage data for their transparency kind of area, just to kind of highlight how infrequently it's being used now. And again, not that they're trying to stand in objection to providing information, but highlighting again back to this point of we're not seeing the use of this, and that may be again something to consider. The final one, I think, which is really interesting too, is transparency tools offer little opportunity to save money. And what they found is, for many kind of patients looking at prospective care, in many situations, they're going to kind of go through their deductible in those situations. And so there's not really an opportunity to maybe, reduce their kind of financial obligations there. So it begins to be very important, I think, in all of this as well. So again, key points to kind of consider. I think, our tone will be everything in how we present information back to CMS. I think if they really see that we want to work with them, but we're trying to point out where things are not technically feasible, I think, again, presented in the right way, I think they will be open to hearing that and making changes. But then also, if we are able to present back alternatives, which again, this is our firm's sort of thought process in terms of providing back alternatives that could be considered. We're hopeful that, again, you will use some of this, modify it as you'd like, but really get back to CMS. Here's what we think is not technically possible, but here's what we think is possible, and in reality could actually help the patient more than what's being proposed, and it probably is more in keeping with what CMS is trying to get at. Again, more at that claim level as opposed to kind of the service or service packages level. And then again, also trying to kind of avoid some of these issues of payer-specific payment, as again, these can be very problematic and challenging to provide. The last slide here kind of provides tools by which you can go ahead and provide your own comments back. So it's a resource page here. You can provide it back electronically. The only comment that I would make there is it is a challenge to find. So the proposed rule provides this statement here. What I've kind of found in here is that you've got to really search for the CMS 1717 and then select comment now. That will really take you to the page that you need to be on. You can go by regular mail, but again, just be advised that you want to provide for time to get those to CMS, and then by express or overnight mail. In the past, we've commented electronically and have not had an issue using that format, with the, again, just exception of trying to look for that search kind of feature in there. I have, we've come to about 10 minutes to the hour. I was hopeful that actually we could kind of save a little bit of time here. I apologize. I am not a good multitasker, so I get very keyed on the slides. I'm now looking at the Q&A screen, and I will try to kind of look through these and see if we can get some comments back. But again, appreciate so much you providing your time today to be a part of this.
Jamie, this is Mike here, just to key in on a couple of the questions. Yes, the presentation was recorded, and we're going to follow up with emails to the attendees with a link to the recording when it's available on our website, along with copies of today's slides and any answers to kind of the frequently asked questions. So check your email boxes in the next few days for those. We'll try to get those out as quickly as possible.
Yeah, that's great. Thanks, Mike. Thanks. So I'll go through a couple of these then too with the remaining time. Question is identified by a common billing code. What about copyright infringement? Yeah. This is really interesting. We have oh, Mike, I think actually if we're getting that feedback a little bit again on where both you and I are on the same line. Great point. What we have heard from folks is that there is a potential here for that issue. The anecdotal comments that I've heard back from CMS is that there is no copyright issue, that there have not been any kind of legal challenges as a part of kind of the reporting that was done on January 1st. So I think it's perfectly reasonable to bring that point up again in your comments. I think it's an excellent one. But again, the anecdotal kind of feedback that we've gotten so far is that because nothing happened so far, they anticipate that additional disclosure to still be okay. Great point, though. Great question there too. If the hospital does not have one of the 70, do they have to make up additional ones? They do not, actually. In the current language, it says that you can use an NA, and that is perfectly acceptable. So, where is the list? The list is actually contained in the proposed rule. We also have that document as well. We're actually providing it right now to folks in a document that we call our Transparency 100. We're taking the 70 CMS ones, and we're already starting to look at 30 additional as hospitals are trying to kind of get a little bit of ahead of the curve and see if there are others. We're using essentially on that document, we're looking at ones that have high utilization by freestanding centers, because we feel like if those are being considered from a freestanding perspective, the patient may be more apt to kind of compare those to a hospital. So we're trying to kind of point those out to hospitals there. Great question. Let's see. Our next one is ancillary and other items, services, employee practitioners, and any other item, service which a hospital has established to charge professional charges. Yes, professional fees are included as a part of the disclosure, but again, our comment back is that that particular area should be removed entirely. So we would definitely recommend trying to provide comment on that. Has the impact of hospitals sharing all payer net reimbursement data per service or payer contract negotiations been addressed? Yeah, this is really kind of, hopefully in some of it looks like this one came a little bit earlier on in the presentation. Hopefully, yeah, this is certainly an area of concern. Legal and a competitive kind of issues there, I think, are paramount. We highly encourage folks to comment back on that, certainly. But yes, it's definitely one that we are commenting back on as problematic. And again, ultimately, the thing that we're trying to promote there is who should be responsible for that. Fundamentally, we think that actually should be held responsible for the payer, not the hospital. I think that's a key point to come to. Payers will be building web scraping tools to use in contract negotiations. Absolutely, this gets into that kind of anti-competitive kind of behavior. Certainly an issue. And again, CMS actually even references that point. So, this is a gut feeling comment, but in the initial executive order, that particular component was one that was called out. So I wonder if they are already anticipating that being a challenge and essentially are trying to, kind of grease the wheel, so to speak, and say, hey, we recognize this could be a problem. So we're trying to reemphasize that point that they've already made, that I think this could be a problem. The next question is, has the AMA agreed to allow hospitals to publish CPT codes on their websites? I have not seen this. Again, anecdotally, I have heard that it was not a problem, and I had heard actually even from somebody I believe on kind of an AHA leadership council AMA kind of leadership council that they were okay in a federal required basically with a federal requirement, they were okay with that disclosure being there. But again, that is anecdotal, so I cannot comment on that definitively. I think it's certainly well worth bringing up in your comments.
Jamie, if you don't mind, I actually could provide some feedback on that particular question.
Great, yeah.
Everyone can hear okay. According to the AMA's website, they did post I think it was earlier this year, as it related to the 2019 inpatient final rule, that organizations that have a valid and current CPT license for their charge master, which typically is a component of their revenue cycle management system, are permitted to host and do not violate the copyright codes as stated by AMA. So as long as you have a valid and current CPT license as part of your revenue cycle management system, you should be okay in that standpoint.
Great. Mike, thanks. That's awesome. Well, that brings us to the end of the hour, and some excellent questions. Again, appreciate so much your involvement and engagement kind of in this topic. Certainly, would welcome follow-up questions, comments that you have. Please let us know. We really are trying to encourage working through this together so that we can provide great feedback to CMS in an area that really will very much could impact all of us to a very certain, very significant degree. So again, if there are follow-up kind of questions, comments, please let us know. But again, thank you so much for your time today. We really appreciate it.